When should we consider a patient with myelodysplastic syndromes for transplantation? It's a good question. And I think we should consider any patient up front for transplantation. Clearly, there are some different factors will influence our end decision, but we may consider any patient at the beginning. Age is one of the main things that we need to consider, but not only the ID card age, but physiological age, more than just the ID one. This is something kind of important, but we also need to consider other factors. Some are disease-related, because MDS is an heterogeneous disease, and not all the myelodysplastic syndromes will evolve at the same speed and with the same consequences. So for the moment, the general strategy is to consider patients for transplantation if they had a low-risk disease, meaning a low risk of progression to acute myeloid leukemia, only in the later stages of myelodysplastic syndromes. We have some times before the consequences of cytopenia became strong enough to consider transplantation and its potential risks. On the other hand, when you talk about high-risk patients with a high risk of progression to acute myeloid leukemia, transplantation should be considered from the beginning. And to decide which patients are low risk and high risk, we rely on all the scores that has been developed along the years. Mostly revised IPSS is one of the key scores that we are using, because with the new cytogenetic classification, with a new way to define blast count, cytopenias, it allows a more precise classification of patients, and it's easier for us to define which patients are considered high risk of progression, which are the ones for which we have some more time. But clearly, situation is kind of easy for high-risk patients. It's pretty straightforward. The question is more for low-risk patients, as consequences of cytopenia are maybe less important, and their life is not at risk just at the beginning. And we may sometimes lose the question of transplantation along the road. But it's important to consider it, I think, from the beginning, especially as patients are aging, and this may represent an issue after. This is really what relates to disease by itself. Other factors are also important when you talk about transplantation. Is a patient going to be compliant with the medication? Is there any kind of comorbidities that may have an impact before, during, or after transplantation? And considering transplantation is not thinking about it and looking for the HLA matching. It's also getting to a really comprehensive workup to be sure that the patient is fit for transplantation. Especially when we keep in mind that most of the patients diagnosed with myelodysplastic syndromes are 60 or older. So this is the population of patients for which the risks of non-transplant, sorry.
It's okay. Just take a second and start again.
This is a population of patients for which the risk of non-relapse mortality is more important. And we really need to have a really, really comprehensive workup for this patient before putting every green lights for the transplantation.